Hello, I'm Congresswoman Debbie Wasserman Schultz, representing Florida's 25th District in the House of Representatives in Washington, D.C. I greatly appreciate the opportunity to join JScreen in the discussion about hereditary cancer and my recently introduced legislation extending coverage for genetic testing and follow-up services. I want to thank JScreen for hosting this important discussion, as well as their dedication to preventing genetic diseases and hereditary cancer. With a mission to prevent Jewish genetic diseases, JScreen makes genetic screening and counseling convenient and affordable. My story began 15 years ago with the harrowing words, "You have breast cancer." I also discovered, like many other Ashkenazi Jewish women, that I carried the BRCA2 gene mutation. That gene mutation made me 5 times more likely to get breast cancer and gave me a 40 to 85% risk of getting ovarian cancer before I was 50 years old. After surviving 15 months of surgeries and treatment in what was a very difficult but private battle, I was cancer-free. My journey of survivorship helped me translate my diagnosis and my story into something greater. We all have a role to play in our fight against cancer. For my part, as a member of Congress, I have the platform and ability to help so many others who've heard those frightening words just as I did. For all of my professional career since my days in the Florida State Legislature, I have been a strong advocate for education, awareness, early detection and prevention, and survivorship. Many priorities in my policy agenda are aimed at enhancing and protecting access to early screenings, one of the best tools we have to beat this disease. I fought relentlessly to pass the Early Act, which created a CDC education awareness campaign that highlights breast cancer risks facing younger women and women at higher risk. It also provides grants to organizations that help younger women with the unique challenges they face when battling breast cancer. I was also able to pass the PALS Act, which protects access to annual mammograms starting at age 40. And finally, I was able to create the LCL Hastings program for advanced cancer screening in underserved communities. This supports health centers' efforts to increase equitable access to cancer screening and referral for care and treatment in partnership with NCI-designated cancer centers. And I'm now working hard to pass a bill that addresses another gap in cancer screening, access to hereditary cancer screening and medically necessary follow-up services for Medicare beneficiaries. To explain, there is an unfortunate reality where, under current law, Medicare covers genetic testing only for beneficiaries already diagnosed with cancer, regardless of family cancer history or a known genetic mutation in the family. This is nonsensical. Let that sink in. If you have Medicare, you cannot get a genetic test until you already have cancer. So if someone without cancer learns they have one of these mutations, a previvor, many medically necessary cancer screenings or risk-reducing surgeries are not covered by Medicare. This is a particularly important issue for families of Jewish descent. The most well-known genes linked to breast cancer risk, BRCA1 and BRCA2, are inherited gene mutations that increase the risk of cancer and can be passed to you from either parent. In the U.S., about 1 in 400 people have these mutations. However, among Ashkenazi Jewish women and men, about 1 in 40 have a BRCA1 or 2 mutation. With certain ethnic groups having an increased risk, and as so many stories show, like my own, it is vital that we address cancer through early detection using all the tools available. The fact that Medicare doesn't cover these potentially life-saving tests and interventions exacerbates health disparities and is also more costly. To address this gap, I introduced the Reducing Hereditary Cancer Act with Congresswoman Marionette Miller Meeks, Congresswoman Alyssa Slotkin, Congressman Larry Bouchon, and Senators Lisa Murkowski and Ben Cardin to ensure coverage of hereditary cancer screening and follow-up care. This bicameral, bipartisan bill would require Medicare coverage of genetic testing for inherited mutations known to significantly increase cancer risk for those with a known hereditary cancer mutation in their family, and those with a personal or family history for hereditary cancer. And for those who inherit a mutation causing a moderate to significant increased cancer risk, this would enable Medicare beneficiaries to get increased coverage for screenings and risk-reducing surgeries. With access to early detection and the realization that someone has a mutation, individuals would be able to better understand their personal risks for multiple cancers and make informed decisions about the type and frequency of cancer screenings. Prevention, rather than remediation, can save millions of lives. As I've emphasized, and as you will continue to hear today, early detection is pivotal. It can be the difference between life and death for people living with cancer, especially breast cancer, and even more so for individuals with inherited mutations like the BRCA gene. During the COVID-19 pandemic, cancer screenings declined drastically, especially in communities of color among Hispanic and American Indian, Alaskan Native women. Sadly, as a result of pandemic-related delays in cancer screening and treatment, the National Cancer Institute predicts that over the next 10 years, there will be potentially tens of thousands more cancer deaths. We need to change this narrative and reverse these statistics by ensuring widespread and equitable access to preventative care, particularly cancer screening. Thank you again for inviting me to speak about this bill, for your support, and for your dedication to eradicating cancer. Always think of me as an ally, warrior, and resource. Together, we will continue to deliver for cancer survivors and their families, and this bill will create another tool in our fight against cancer. And now we'll be hearing from Emily Goldberg, a genetic counselor who will be discussing how genetic testing can reduce morbidity and mortality and why you shouldn't wait until you already have cancer. Thank you so much.
Thank you, Congresswoman Wasserman Schultz, for sharing your story and introducing this important bill. As a genetic counselor for over 12 years, I've counseled thousands of patients about genetic testing for hereditary cancer. We've discussed the ways that these results can impact their health and inform medical management. We've spoken about numerous options, including preventive surgeries, increased surveillance, and guidance for cancer treatments. I've witnessed firsthand how this information can be life-changing for patients, their caregivers, and their family members. Like my BRCA1 positive patient who was diagnosed with stage 1 ovarian cancer, found during a surgery that was meant to be preventive. Without this intervention, she would have received a later diagnosis of stage 3 or 4 cancer with a very different and grim prognosis. Or my patient who was found to be high risk on genetic testing, had a breast MRI to be extra careful, and was diagnosed with an early stage breast cancer that was missed on routine mammogram. Genetic testing changed the direction of their lives, and there's no substitution for this information. We know from decades of data that genetic testing saves lives, reduces morbidity, and empowers. It's not new, it's not experimental, and it's recommended for those who are at a high risk by the most senior medical experts in this country, including those at the American Society of Clinical Oncology and the National Comprehensive Cancer Network. There are countless studies in prestigious medical journals about how positive genetic testing results, especially those received before a cancer diagnosis, can greatly impact one's physical and mental health. These numbers don't lie. From a humanitarian perspective, it will greatly impact the lives of millions of people. People who are aware of their genetic risks are able to feel empowered by making an actionable plan to prevent cancer or detect it at an earlier, more treatable stage. They can reduce or avoid the immense pain and suffering that goes along with a diagnosis of cancer. They can participate in research and clinical trials to further our knowledge in these areas to affect generations to come. They can connect with other individuals and families who have shared predispositions and experiences. And they can share this information with their relatives who can make their own informed decisions about genetic testing and cancer screening. From an economic perspective, genetic test results from one simple blood or saliva test has the power to prevent years of expensive treatments, including chemotherapy, radiation, and surgery. Even with added screening or preventive measures due to a positive result, these financial costs are minimal compared to the treatments required for an advanced stage cancer. The fact that Medicare does not cover genetic testing for people without a cancer diagnosis, even when there's a significant family history or a known genetic mutation within the family, is unacceptable. This decision is predicated on outdated information. It contradicts recommendations from leading experts in the field of genetics and oncology, as well as a patient's trusted healthcare providers, and it adds to the inequities in healthcare in this country. Why are we waiting for an entire generation of people to develop cancer when we can do something to avoid it? Isn't it better to be proactive than reactive? Let's get this bill passed and change the story for so many. Thank you for your time. We're now going to hear from a woman with a personal story to share.
Thank you, Emily. My name is Anna Jo Smith. I'm a gynecologic oncology fellow at the University of Pennsylvania and from a family impacted by hereditary cancer syndrome. Improving access to genetic testing is essential for my patients and for my family. Thank you to Congresswoman Schultz for her ongoing championship of the Reducing Hereditary Cancer Act and improving access to genetic testing for the 65 million Americans with Medicare. I'm going to start with my story. My dad was first diagnosed with prostate cancer when I was in medical school. He had surgery, and by all accounts and by all statistics, should have been cured. But his cancer recurred rapidly, leading me to suspect a genetic syndrome. His oncologist also recommended genetic testing. As my dad had just turned 65, we investigated testing options through Medicare, as well as through his supplemental private insurance. However, for men with prostate cancer, Medicare did not cover genetic testing beyond BRCA, and we were concerned about other hereditary cancer syndromes. We ultimately did direct-to-consumer genetic testing because of the cost and comprehensiveness. This testing uncovered that my dad had not one, but two inherited hereditary cancer syndromes with mutations in the ATM and BRIP1 genes. Both ATM and BRIP1 are associated with increased risk of prostate cancer, as well as breast, ovarian, pancreatic, and skin cancer. And these gene mutations are relatively common. Around 1 in 200 people have mutations in the ATM gene. And BRIP1 is actually the third most common gene associated with ovarian cancer after BRCA1 and 2. For my dad, being diagnosed with these mutations directly impacted his cancer treatment options. Having the ATM gene made him eligible for newly FDA-approved treatments known as PARP inhibitors, an oral cancer treatment option for his cancer that otherwise he would not have received. You can only receive those treatments if you have an identified genetic genetic mutation, and you can only be identified with a genetic mutation if you have genetic testing. Moreover, he needs enhanced screening for his other cancer risks, such as skin cancer and pancreatic cancer, through dermatology visits and endoscopy that would not have been needed prior to him being diagnosed with hereditary cancer syndrome. However, the hereditary cancer syndromes my dad has been diagnosed with would not have been identified with genetic testing covered by Medicare. The Reducing Hereditary Cancer Act would help Medicare patients like my dad get necessary genetic testing, enhanced screening, as well as access to genetically targeted therapies they need. As an oncologist, as well as a daughter, cousin, granddaughter, aunt, the next step in all of this is getting the rest of our large rural family screened for the ATM and BRIP1 mutations, the hereditary cancer syndromes identified in my dad. As an oncologist, I would love to prevent my relatives from getting cancer if I can. As a gynecologic oncologist, I treat women with ovarian cancer day in and day out, most of whom present at a late stage of diagnosis and die of their cancer after a few years. Risk-reducing surgery, such as removal of the tubes and ovaries, can prevent the risk of ovarian cancer by over 80% in women with hereditary cancer syndromes. Providing these surgeries, called risk-reducing surgeries, is part of my job as a GYN oncologist and something I feel very passionate about, both for my patients and my family. Yet Medicare, even once patients are diagnosed with a known hereditary cancer syndrome, does not cover these vital risk-reducing surgeries for patients with hereditary cancer syndromes. The Reducing Hereditary Cancer Act would help change this and provide patients with hereditary cancer syndromes access to recommended screening and risk-reducing surgeries. So far, in our family, 4 other family members have had genetic testing, and the majority have tested positive for one or both mutations, either in BRIP1, ATM, or both. My younger relatives who have tested positive are currently getting enhanced screening because of their hereditary cancer syndromes, including breast MRI, yearly skin exams that their private insurance has been covering. However, once my relatives turn 65, Medicare does not cover these recommended screenings to reduce the risk of cancer. And they'll have to pay out of pocket to get the recommended options to prevent them from developing a cancer in the future. Again, the Reducing Hereditary Cancer Act, by improving coverage for screening once people are diagnosed with hereditary cancer syndrome, would help prevent cancers in individuals with Medicare. So again, I just mentioned I'm a part of a large rural family. We're still trying to get the remaining dozen or so family members access to genetic testing. However, most of them have Medicare and lack the resources to pay out of pocket for testing. Out-of-pocket testing for genetic syndrome can cost a couple $100s out of average, which is not affordable for many members of my family, as well as for millions of Americans. Cost is a major barrier to testing. It'd be much better if Medicare would cover genetic testing, as well as the needed high-risk screenings and risk-reducing surgeries. Why are we using the tools at our disposal to identify high-risk individuals who meet the criteria for genetic testing? Why doesn't Medicare aim to prevent or catch cancers earlier? 65 million Americans have Medicare, and preventing cancer would save lives and money. The Reducing Hereditary Cancer Act can save lives by allowing high-risk individuals, like my father, access to genetic testing and needed screening through Medicare. And for my relatives, it would provide further access to genetic testing, as well as access to risk-reducing surgeries when indicated. Having Medicare cover genetic testing would help my family, as well as all the patients I care for as a GYN oncologist. I'm now going to pass it to Dr. Jane Meisel, a medical oncologist and director of JScreen's Cancer Genetics Program.
Thank you so much for sharing your story. That was great. I'm Jane Meisel, an associate professor of medical oncology at Emory with a clinical and research focus on breast and gynecologic cancers. I'm also the medical director for JScreen's cancer screening program. So because of these two roles, I spend a lot of time talking with patients and just with people generally about genetic testing. And I really enjoy counseling women who are found to have genetic mutations about what these mutations mean for them and what they want to do about the information. So I think backing up to who needs genetic testing, because people often come to me with questions about that as well. Should I have genetic testing? I think as a physician, decisions about whether or not to send a certain test, whether it's a blood test, an imaging study, a genetic test, for me comes down to whether the information the test gives us would change our management. And for genetic testing, it almost always would change your management because knowing whether or not you have a genetic mutation that predisposes you to cancer can help you understand your risks for certain cancers and your options for risk reduction and treatment. So when someone comes to me knowing that they have a mutation in BRCA1 or BRCA2, the question is, you've got these genetic mutations that confer an increased risk of certain cancers, and what do you want to do about it? And I think that can be very individualized, but there's always something that you can do to reduce your risk. So starting with breast cancer, some background on that, and I think this is in some ways been said already, but just to reiterate, all women without a BRCA mutation have about a 12% chance of developing breast cancer by the age of 70. But if you have a mutation in BRCA1 or BRCA2, that risk goes up significantly, upwards of so anywhere between 50 to 87%, depending on which study you look at and which mutation you have. The BRCA-associated breast cancers are also more likely to be found in younger ages. In my clinic, I often see patients in their 30s or even occasionally in their 20s with breast cancers associated with BRCA mutations. So given this high lifetime risk, women who know they carry a mutation in one of these genes are recommended to do either additional screening, so that can be in addition to mammograms starting at age 40, actually alternating breast MRIs and mammograms every 6 months starting at age 25, or undergoing prophylactic bilateral mastectomy, meaning removing the breasts entirely, often with reconstruction, so that you don't just have a flat chest, but you have reconstructed breasts, and that reduces the risk of breast cancer significantly. And I think doing either of those things, either the enhanced screening or the surgery, is not something that people can just make a snap decision about. It requires some thought, often discussion with family. But again, important to know that you have these options to reduce your risk of breast cancer with surgery, or to find breast cancer early when it's easier to cure and more treatable with the enhanced screening option. So this is something I talk to patients a lot about. And then ovarian cancer is another thing. So the risk of ovarian cancer, as many of you know, is significantly higher in women who carry a mutation in the BRCA1 or the BRCA2 gene. The average lifetime risk for ovarian cancer in the United States for women without a mutation is somewhere around 1 to 2% lifetime risk. But for patients with a BRCA mutation, it can be as high as 50%. The ovarian cancer risk is classically higher in patients with BRCA1 mutations than BRCA2 mutations. And it's also higher if you have a strong family history of the disease. So if a patient comes to me and they have a new diagnosis of a mutation in one of these genes, and they have a family history of women who have been diagnosed with ovarian cancer in their 40s, that worries me a lot more than someone who comes with a mutation but has not had a family history of ovarian cancer. I think the challenge with ovarian cancer is that we often, really can't screen effectively for this disease because of where the ovaries sit in the abdomen. We often don't have symptoms of ovarian cancer until the cancer has reached an advanced stage. And that's why many women with ovarian cancer are actually diagnosed not with stage 1 or stage 2 disease, but with stage 3 or stage 4 disease, which is most of the time not curable, can be treatable, but people often do die of that illness. So many women with BRCA mutations who know they have a higher risk of developing ovarian cancer will actually elect to have surgery to prevent the cancer from occurring. These are actually pretty easy surgeries, but the counseling around them is complex, and I think requires some decision making with the patient and their family and their doctor. Because the surgeries involve either removing the ovaries, which can be done once a woman has done childbearing, but then you also have to kind of balance the risks versus the benefits of removing the ovaries before you would naturally go into menopause, because there are some benefits to the heart and for bone density and things like that to having estrogen production up until you would naturally undergo menopause. So these are conversations, again, that women need to have with their doctors and with their families so that they can decide when the right time is to do that surgery for risk reduction. And the other interesting option for risk reduction for women with BRCA mutations looking to reduce their risk of ovarian cancer is actually something called salpingectomy. So what that is just removing the fallopian tubes, the tubes that connect the ovaries to the uterus. And what salpingectomy does is actually reduce the risk of ovarian cancer significantly. Some would say up to 65 to 70% risk reduction. The reason we think that is that most cancers that we sort of identify as ovarian cancer probably start in the fallopian tubes. And then those early cancer cells settle either on the tube or on the ovary or in the lining of the abdomen called the peritoneum. And so the type of cancer that people develop that we refer to as ovarian cancer can either be ovarian, fallopian tube, or what we call primary peritoneal. It's all the same biology. So what we found is that removing the fallopian tubes, called salpingectomy, can also be done to reduce risk. So if a patient comes to me and has a strong family history of ovarian cancer, but they're not yet ready to undergo premature menopause, salpingectomy, which is a pretty minor procedure, can actually be done as well and can reduce the risk. You wouldn't do that in someone who hasn't completed childbearing yet, but in someone, say, who's 30 years old, has had 2 kids, maybe isn't ready for menopause, but has a strong family history of ovarian cancer, that could definitely be an option as well. So I think this is where, and you get the sense that the counseling around this is very personal and requires a lot of intricate decision making, but you can't make these decisions if you don't know. And that's why genetic testing and screening can be so important. So that's breast cancer and ovarian cancer. And there are other cancers that are at increased risk for patients with BRCA mutations too. So pancreatic cancer is one of the cancers that we think about. That's also like ovarian cancer, a very difficult one to diagnose because people don't typically have symptoms of pancreatic cancer until it's at a later stage. And that's why we often diagnose pancreatic cancer in this country at late stages where it's not curable. And unlike ovarian cancer, we really don't have great treatments for pancreatic cancer. So once patients are diagnosed with incurable pancreatic cancer, the survival is really quite short. So diagnosing that early is also really important. Pancreatic cancer is not as high risk as breast or ovarian cancer, not at all. And so screening is actually only recommended in a BRCA mutation carrier who also has a family member with known pancreatic cancer. But in those patients, they actually can do screening for pancreatic cancer, alternating every year endoscopic ultrasound or MRI. So this is something where if a patient comes to me and they've got this mutation and they've got a family history of pancreatic cancer, I would then refer them to one of my colleagues in the gastroenterology clinic who does this kind of screening and get them set up for an initial visit. So again, this is multidisciplinary, involves multiple different physicians often, but you can really get the right personalized screening and prevention plan in place for these patients once you know. And then skin cancer is another thing. So patients with BRCA mutations are at slightly increased risk for skin cancer as well. That's an easier one to screen for because it's visible on the skin typically, and if you're looking for it, you can sometimes find these cancers early. So we recommend skin protection with hats out in the sun, sun protection with sunscreen that has high SPF, usually over 30, and then a yearly evaluation with a dermatologist just to do a full skin check to make sure that if we have skin cancer, we're catching it at an early, treatable, curable stage. And then what about men? Men are often, coming to me saying, should I even have this testing? Does it matter for me? I don't have breasts or ovaries. So men can get breast cancer, and actually male breast cancer is higher risk in patients with BRCA mutations, particularly in patients with the BRCA2 mutation. So for male breast cancer, it is good to know if you've got that gene, just so you can be on the watch. If you develop a lump in your breast and you've got a BRCA2 mutation as a man, you want to know not to write it off as nothing. And prostate cancer can also be higher risk for men with BRCA1 or BRCA2 mutations. And so that would be an instance where men would want to sort of get together with their doctor and discuss a personal plan for prostate cancer screening based on their own personal feelings about it and their family history. And then I think in addition also to managing your own health, if you know that you've got a mutation in a BRCA1 or BRCA2 gene, this can also inform what your family members want to do about their health and their healthcare screening. So if someone has a BRCA1 or BRCA2 mutation, they either inherited that mutation from their mother or their father. So that'd be interesting information for those parents to have so they can figure out, which one of them carries the gene if they don't know already, and then choose whether or not to get testing so they can employ their own risk reduction strategies. And then for people's children and siblings, it's also an interesting thing to know about because those children and siblings may want to also get tested to see if they carry the gene. Because again, then they can perform these same preventative strategies that we've talked about. And I think the other thing, and this is a little bit more controversial and potentially, something just to think about, is that for folks who find they have a BRCA mutation but have not had children yet, there are actually technologies that can be used if they choose that they don't want to pass those mutations on to their children. And if they're using assisted reproductive technologies, those embryos, if they're again using reproductive technology as opposed to getting pregnant the natural way, embryos can actually be tested to see if they have the gene. And then people can choose to implant embryos that do not carry the genetic mutation. So these are options, again, just options to discuss. And I think that's why, in my mind, genetic testing is so important, because if you get tested and you know whether or not you have a mutation, then you can take all these potential strategies into mind to potentially prevent risk of cancer. And it's a lot easier to prevent cancer than it is to treat cancer. And I think a lot less psychologically damaging in many ways, because if you don't have to go through chemotherapy and cancer surgery, which is often a little bit more kind of longer surgery, sometimes more morbid surgery than risk reduction surgery, it definitely can be better for the patient and for the healthcare system in general. So that's really all I have. I thank everyone for listening to this presentation today. I hope you all found it informative and interesting, and potentially thought-provoking for the future. Thank you again.